Très bien, et bonsoir à tous. Merci d'être venus donc, pour cette première conférence sur le secours en montagne portée par Urg'ARA, la faculté de médecine de Grenoble. Donc heureux de vous accueillir ici pour ce soir. Et on a pour cette première vraiment des experts sur le secours en montagne. Donc deux Italiens, Giacomo Strapazzon et Herman Brugger, qui travaillent donc au centre de recherche de l'EURAC sur le secours en montagne et qui donc vont vraiment nous apporter leur expertise sur le sujet. Et puis Bernard Marsigny, c'est ça, de Chamonix, pour un peu d'historique sur le secours. Historique, c'est ça, sur le secours en montagne à Chamonix, donc les débuts, les premières ECMO, et voilà, donc ça va être l'histoire. Et puis je vais tout de suite laisser la parole à François.
Merci Guillaume. Je remercie vivement la faculté de médecine, le CHU, pour nous avoir permis d'organiser cette conférence qui a été précédée du webinaire de la filière Avalanche du réseau d'urgence Auvergne-Rhône-Alpes. Alors moi j'ai plusieurs casquettes, je travaille ici après une longue carrière en Maurienne, mais aussi je représente l'Association nationale des médecins et sauveteurs en montagne. Et l'idée nous est venue de faire cette conférence, ce webinaire, en marge de ce qu'on fait depuis une dizaine d'années, une formation sur la prise en charge médicale des avalanchés, qui est devenu un truc qui s'appelle Frédière, parce qu'on fait ça à Frédière. Donc Frédière, c'est the place to be pour apprendre à prendre en charge les victimes d'avalanches. Cette année, c'est une date anniversaire parce que, comme on disait pendant le webinaire, il y a 20 ans, on a eu la pire saison d'avalanche avec 50 décès dans l'hiver. Et puis, c'est aussi un anniversaire assez triste parce qu'il y a 10 ans, quasiment jour pour jour, survenait une avalanche en Maurienne, au col du Petit Argentier, en montagne, qui a emporté 33 militaires qui étaient en entraînement et dont 6 sont décédés. Et cet accident nous a un petit peu marqué. Et voilà, ça fait 10 ans. Donc pour les anniversaires, le processus de retour d'expérience et de ne pas oublier ce qui s'est produit, même pour ceux qui n'étaient pas encore dans le secours, est important pour éviter de revivre les choses. En tout cas, si on y est confronté, d'avoir tiré toutes les leçons de ces accidents. Je remercie aussi le public qui est... Et alors, il y a un petit peu toutes sortes de profils. Il y a les gens du secours, il y a les médecins du secours, il y a les réanimateurs, il y a les urgentistes. Et puis il y a aussi les futurs médecins. Et quand j'ai demandé à nos collègues Giacomo et Herman de bien vouloir nous faire une conférence, je leur ai dit, voilà, dans le public, il y aura des jeunes et vous devez leur donner envie de faire de la recherche. Alors du secours, ça, on sait qu'ils en ont envie, mais pour faire progresser le secours, il faut de la science, et pour ça, ça ne se fait pas tout seul. Et je les remercie d'être là. Donc, Giacomo et Herman sont des amis. On se côtoie au sein de la commission médicale de la Commission internationale du secours alpin depuis nombreuses années. C'est des gens très sympas, très compétents, très disponibles. Et quand ils parlent en anglais, eux, on les comprend. Donc... vous allez voir, ça va bien se passer. Et puis, du coup, pour les situer, Herman, il n'est pas que médecin, c'est aussi un guide de haute montagne. Et c'est quelqu'un qui a, il y a une trentaine d'années, travaillé sur les courbes de survie, qui portent son nom, et puis qui a continué de travailler. Et ça, il vous en parlera. Et c'est un outil quand même précieux. Giacomo a pris la suite de Herman à l'EURAC, et là il va vous parler de recherche expérimentale Vous allez voir, hein, c'est quand même assez spectaculaire. Ils ont un outil qui est fabuleux et je pense qu'il va nous en parler. Ce que je vous demande, c'est de ne pas hésiter à un moment donné de poser vos questions. Et puis voilà. Donc, je propose de donner la parole à Giacomo. Et let's go with your show.
Bonsoir, tutoir, and merci to François, Professor Debatty, and Mark, and everyone for this kind invitation. Sorry for speaking in English, but I think it's much better when I speak in English than in Italian. And first of all, I have no conflict of interest about my presentation. And in this 45 minutes, I will try to go with you about research in avalanche, and I will focus in my part of the presentation about what happens to our body where we are critically buried. But before this, I will also say about some other kind of research or information that is very useful when we plan the rescue, when we organize the resources, but is also to know how the people go in the mountain, approach winter environment, and how these things also help us to understand what happens then to the body when we are fully buried. I will present to you both some human and animal studies, because according to what we have to investigate, also due to some ethical concern, we have to choose maybe to use animal model, unfortunately, sometimes. And I always try a bit to focus on the implication that all the study that we have performed have an impact on avalanche rescue. And I will left to Herman after me to speak mostly about clinical study and things. So I would like that this presentation also inspire you about to do research. You will see how exciting can be this kind of research and also challenging. And I will spend, I think, much more time talking of our latest study that was just published in JAMA a few months ago, that I think is quite exceptional for a quite niche topic, but also show how if we plan well medical research, even in difficult environment, we can obtain a very strong and robust result. So let's go on. First of starting, just a couple of pictures to show where I live. I live in the eastern side of Italy, in the Dolomites. So the mountains are not so huge and high like here, but there can be spectacular. So when we have good snow condition, that is quite rare, actually with the climate change, we can have excellent, and it's very nice to practice ski touring. And we know that practicing this mountain activity is also the main reason to be catch in an avalanche. 90% of the avalanche where a person is involved are caused by the person itself. So we are the cause of triggering avalanches. And when we trigger an avalanche, before mountain rescue arrive, our companion should be able to do self-rescue. And overall, even when we have a well-organized healthcare system, the scene can be quite tricky. And these are some images of one of the latest big avalanches that we have in South Tyrol. And Herman will present in detail this. But I just start with this because I want to show to this that when we have to operate in this environment, we need to have technical skill, we need to be capable to manage logistic, and then when we find our patient, we need to understand what has happened to his body while he was under the snow. But before going on this point, I just wanted to do a step back. And I just want to remind to you that probably the base of this pyramid, the prevention, is one of the most important points. We should try to avoid to trigger an avalanche. And some years ago, we decided to do, to do a good prevention, for sure we need to read the avalanche forecast, but we need also to be prepared and trained to use this tool in the field. And for sure, to be prepared and trained and informed, we can use the web. And some years ago, we decided to do a research, and we tried to see why people search online the term avalanches. So this research was mostly involved in Italy. You can see on on your left side a bit the panel of the region where most of the avalanche happens, and this show a bit the places where there was most of the search, and for sure they are along the Alpine ridge. And then you see in the upper figure all these peaks. And these were the moment when the people were searching for the term avalanches. But people are searching for the term avalanche not to get informed, not to get prepared to the environment. They just search it when there happen an accident, and everyone want to know more of how many people has died, but not to get informed. This is very important also to understand how to reach the population, the recreationists, or the worker who work in winter environment. And to understand well how many, the population who are exposed to a risk of avalanche, some years ago we have do a census in South Tyrol. So before we survey in one day all the 143 points that you see in this white circle in our province, where start usually in the ski tour. And then we choose the 22 points where most of the people start. And we discover that within 1 week, we have almost 6,000 people ski touring around, only in South Tyrol, that is a region of 500,000 people, so not so much, and in around 2,000 groups. This is very important because in most of the statistics, we know how many people die per year, but we don't know the real risk of practicing ski touring. I don't know if you know here in France, but it's extremely tricky. But if we want also to invest the resources, we have also to know a bit what is the real risk and the real burden compared to other kind of accident. And we discovered that the amount of people who practice ski tour is high, 80%, but there is also a lot of people who go snowshoeing in winter environment, 22%. But it's not a so low percentage of people. We see, as probably we can suspect, that most of the people practice this activity during the weekend, where we have a peak, even if the avalanche risk is higher compared to the other day of the week. But during this survey, we also try to understand if the people know and understand the avalanche bulletin, so they can low the risk to be involved in an avalanche. And you can see on the left side the panel of regarding ski tourer. Let's focus on this, and you see that more than 20% of the group has not consulted the bulletin, and and even when they read it, 25% of the people has not interpreted in a correct way. So almost 50% of the people who go in the field don't really know where they are going. And this is probably one of the big reasons why we have an avalanche accident that actually could be not so much as we expect. We also try to see if the people have safety equipment when they go in the field. And these are the results. So you see that 90% of the people has the transceiver that you know that is essential to be found, but also to search our companion where they are critically buried. but still 10% don't bring. And if we give a look to the standard rescue equipment, that should be the transceiver, the shovel, and the probe, almost 20% of the people don't have. But if you ever do any course about ski touring or anyway going in a not controlled winter environment, you know that it's impossible to locate and to onboard the person if we don't have all this free equipment. And the statistics are quite dramatic. If we go to see the snowshoer, you see that 86% of them don't have. The same we could say also for some devices that represent the safety equipment. You see that the flotation device, the avalanche airbag are brought in a very few percentage, and also the artificial air pocket devices, almost no one has them. And I start from this point to introduce what happens when we are buried in an avalanche. And just to go quickly about the usage of the airbag backpack. This backpack, when is activated, allowed us, as we increase our volume, to stay on the surface of the avalanche. And so there was always a big question, are they efficacious? Can really allow us not to be buried? And what is the level of efficacy that has this device? So to understand this, we need to perform a study that analyzes accidents where not only people with an airbag or without an airbag were involved. We needed to use another methodological approach. We needed to get avalanches where we have people both with the airbag and without the airbag, and see what happens to these two groups. And a big problem that we have always in avalanche research is the number. So you see this number, this study involved 425 victims from around 250 accidents, but we have to recruit them from many countries. Only put data together allowed us to have a more reliable result, because it's a quite, let's say, luckily, rare event. And if we collect the data from every single nation, we have big difficulties to understand in the long time, or it takes many years. Put together the data allowed us maybe to have more robust data to develop international guidelines. And to see the effectiveness of the airbag in this study, we try to evaluate the critical burial. That means if the person was fully buried, so if the person has the head and the thorax under the snow, or if he was only partially buried. And then the mortality, so how many survive after the accident. So an interesting thing that, for example, to collect this data teach to us is that in 20% of the cases, so 1/5 of the cases, actually there was no inflation of the avalanche equipment. And this recall to the problem of training and preparedness. It's not enough to have the tools with us. We need to be trained to use, and we need to be prepared to use when we have an unexpected event like is triggering an avalanche. In fact, you see that the main reason to have non-inflation airbag is failure of the user. This means that people are not able to activate because they are not expecting what is happening in an avalanche. So when you are in this environment, but also when you work as an emergency physician, always try to face the situation in order that you can use the tool that you have in the correct way, and you are not unprepared. And then we try to calculate the just mortality, that is just the multiplication for the just risk of critical buried and the just mortality. And just to summarize a bit, the result is, if we get 100 of people, we see that 22 out of 100 without no airbag will die. But if we have an airbag backpack, 13 out of 100 will survive. Actually, 11, because you see these two are the people who are failed to activate the device. So it means that overall, to have this kind of device, allowed us to reduce of 50% the mortality. Okay, so it's not efficacious in all the cases, but it allowed. But it teaches us also, or it suggests us the importance to have the head and the thorax out of the snow. And this is an old picture that Herman has that showed this woman. This woman was catching an avalanche, but she's smiling. And why she's smiling? She's smiling because she survived. And she survived, why? And this is well shown by this data. These are epidemiological data, so it's data taken from the statistic of how many people were extricated dead or alive after being caught in an avalanche. And we see that if the person was critically buried, more than 50% of the people died. But if the head and the chest were out of the snow, less than 5% of the people die. So we see that if our head is out, then we have a good chance of survival. But we don't have to forget one thing. I didn't show now all how is the dynamic of an avalanche, but when an avalanche fall down, we can have a big speed, and often we can be involved in a terrain where there are trees, where there are rocks. So one of the main causes of death in an avalanche, not the first, but one of the main, are trauma. So we have always to consider avalanche patient like traumatized patient. And often, and probably for the one of you who has followed the webinar before, as was shown well by Marc and François, there are a lot of people who die due to traumatic injuries, but usually involve the head and the chest and the spine of the person. So let's go back again to the situation when now we have a critically buried person. So we found our person under the snow. So what has happened to this person? This picture that we developed last year try to summarize what happened to the body where we are critically buried. And I would like to start with this part. You see there are the highway, there is some, and for sure for breathing we need the oxygen, and we expire the carbon dioxide. But we can do this only if our airway are patent. If our airway are blocked by snow debris, we go quickly against asphyxia. And this is one of the main reasons to die by an avalanche. But even if our airway are patent, there can be an accumulation of carbon dioxide in front of our mouth. And with the Bohr effect, this can displace the oxygen in our lung. And this can create, in another way, asphyxia. And this is well described by the avalanche survival curve that you can see on your right. I won't go in detail on that because Herman will describe to you well how they well develop, which is not simply the result of how many people are extricated alive or not, but there is much more. But I'm interested just to show you that in all these curves that are from Austria, Canada, and Switzerland, actually, we are the same both in France and in Italy. We still don't have an avalanche survival curve, even if I see that you are going to do before us. But in all the curve, we see this big drop in the survival probability in the first 45 minutes. So this is something that has remained. Actually, in the latest curve, this has even been anticipated the starting of the drop. So let's see what happens to the body. And let's see by which study we understand a bit more. So the first study is a study that we haven't done. This study has been done by some colleagues in the Czech Republic. And they wanted to see the effect of breathing in the snow with an air pocket, that means a space in front of the mouth and the snow, or without. So they just create an artificial avalanche. They just put a tube for inspiration and one for expiration with a one-way valve. And then they put some people breathing outside, checking well one important thing is that there was no leakages, because if we have some leakages, then all this study become not reliable. And they could demonstrate, you see in this red line, that the people, in the epsilon axis, we see is a measure of the breathing effort that we have, that in people who don't have an air pocket, they do a very big breathing effort, especially in the first moment of burial. But after that, this becomes quite similar in around 5 minutes, with the one who has the black line and air pocket. This means that we can create an air pocket, also breathing, but also show us that this breathing effort at the beginning could speed up actually the asphyxia process, because we can produce much more and much more quickly carbon dioxide in the initial phases. And again, the epidemiological data always help us, and these are some data that are collected from Austria, and you can see that above 15 minutes there is a big difference in people who survive or not based on the presence of the air pocket. Almost no one without an air pocket, even with patent airway, survive, only 4%, but when the people has patent airway and an air pocket, almost 70% survive. But we also see a big limitation of all avalanche study again. You see the number, absolute, 3 and 29 patients, or before 25 and 122. So a very big difference to other field of medicine, when we have thousands of data per year, and where we can, and this result in very robust information. Okay, so this just to show you what can be in our images, and just to fix what could be an air pocket. What happens while we breathe in this air pocket? So this has been shown the first time in 23 by Herman. He performed a study where people were breathing in air pocket of different size, 1 and 2 liter, and he analyzed what happens to the main physiologic parameter, but also to the gases that are inside the air pocket. And here you can see the variation in peripheral oxygen saturation. This is the end-tidal CO2, these are the oxygen level, and these are the carbon dioxide level in people breathing up to 40 minutes in the snow. And you see that in most of the people, we have this decrease in peripheral oxygen saturation and an increase in end-tidal CO2. And this is mostly reflected by this big drop in the inspired fraction of oxygen, that from 21% goes down to 10%, and from the increasing carbon dioxide, that you see that is already above 4 or 5% in 4 or 5 minutes. That is something not spectacular we can expect from a physiology. But this taught us a lot about why people get suffocated in an avalanche. And always in the same study was shown also another interesting point. So if we compare the delta, so the decrease in peripheral oxygen saturation, we can see that the drop is much bigger when in the one who are breathing inside the 1 liter air pocket compared to the one who are breathing in a 2 liter air pocket. So this means that bigger is the air pocket, more we can survive under the snow, ideally. Then there are a lot of co-complications like the trauma. And I think another study made by the colleagues of Colorado, and especially by the group of Scott McIntosh, show us in another way that this principle is really true. So in the last year, developed a new kind of avalanche backpack. So they are not activated by gas inflation, but they are activated by an electric pump, and so they are filled, this 150 liter balloon, by ambient air. And this device, especially some of them, can deflate after 3 minutes. He demonstrated that actually, at least under experimental condition, they can create a big air pocket of 150 liter. And he say, does this can affect the survival of the completely buried people? And actually, yes. So here are the value of the 12 participants who participated to the experiment. The maximum length of the experiment was 60 minutes. And you can see that in the group, in everyone, they were capable to maintain the same peripheral oxygen saturation, but also more or less the same entitled CO2 from the beginning to the end of the test. So this really means that if we have a very big air pocket, a lot of air inside, probably we can actually breathe like we are outside. And I think this is a quite elegant way to show. But the snow is quite complex. So let's make a jump back to the epidemiology. And before that, let's think also to the kind of snow that we can find. So if we go to ski, for example, in Japan, we are quite near to the sea. And a similar situation, we could also think if we go to ski, for example, in Norway, that has become quite popular in the latest year, like in the Lingen Alp or around Tromsø. And this snow can be quite different from the snow, for example, that we can find in North America, in the inner part, for example, of Canada, where we will have a much lighter snow, so with a very lower snow density compared to the previous one. And actually dividing the survival curve of Canada per geographic region, so that means the region more near to the ocean compared to the region more to the inner region of the Rocky Mountain, you can see in this purple line that in the maritime area, so the one near to the ocean, almost no one survived more than 25 minutes, okay? And one of the reasons that we try to explain this observation was that probably in this region the snow is much higher. And so, and why this could have affected the survival? For sure, we can think that if we have a heavier snow, this can create, for example, more trauma. But an interesting thing comes out with some other study. So I will show you in now almost more than 10 years ago, we decided again to repeat a study, a human study. So in the Dolomites, we build up this artificial avalanche. We dig inside a cavity in our pocket, and then we seal it with this metal screen, and we put 12 volunteers to breathe inside the air pocket up to 40 minutes or until the peripheral oxygen saturation drop below 75%. That is a quite low level that we could almost obtain if we are on the top of Mont Blanc. So the study was a kind of crossover study, and the people perform 3 tests in 3 different months. So one in January, one in February, one in March. What was the purpose to perform this test in different months? It was to try to get all the snow condition, or as much as possible of the snow condition, because we would like to verify if this observation that we have made by the survival curve was true. And these are the Kaplan-Meier curve that we obtain. So this on the y-axis is the interruption rate due to hypoxia, and here on the x-axis you can see the time to interruption. And you can see that in one there was one group who almost never stopped due to hypoxia, but one group, this black line, already after 10 minutes, 60% of them interrupt due to hypoxia, to the saturation. And this was the group who were breathing in a snow with a density higher than 300 kilogram per cubic meter. That is a medium density snow, it's even not so high. So to try to understand why someone are capable to breathe and someone stop, let's see what we have done, like controlling this test. So the air pocket has a volume in this test of 4 liters, and we try also to make some control tests where people were breathing in a plastic bag filled with 4 liters of air. How much you would resist breathing in 4 liters of air before desaturating more than 75%. Do you have an idea? Few minutes, okay? You quickly use all the oxygen. So 100% of the people stop the test in 2-3 minutes, okay? So why in the test the people under the snow were breathing so long? Actually, this is the CT images of a piece of snow avalanche debris. It's like a kind of Urg'ARA. It's full of hole. So actually, in a snow of 350 kilograms per cubic meter, 70% of the snow is occupied by air. So this study indirectly shows us in a very elegant way and other things. When we are critically buried, and if we have our airway patent, we can use the oxygen that is entrapped in the surrounding snow, and somehow it seems that the snow buffer a bit also the carbon dioxide. Because we have to think that with the warm air will create a liquid film around the snow, and we know that the carbon dioxide is very soluble, no? So this was at least this demonstration that seems of a quite unusual situation, because when we are immersed in the water, for sure we can't use or we can extract oxygen in the water. When we are in the air, we can use the oxygen, but when we think that we are filled completely buried in the snow, probably we don't think that we can use the oxygen entrapped, but actually we can. Looking always this important of exchange of gases, there was also some other interesting study that has been done. So this is an old study, you see, 2001, and actually was also published in JAMA. So it was a very elegant study done again by colleagues of Colorado, Colin Grissom, to test this artificial air pocket device. How works this device? This device actually has a tube who finish in this mesh area with where actually where the inspired air is taken. So, but when we expire, there is one-way valve that push the air that we expire on the back of our body. So actually, we don't rebreathe our expired air. So it means that the air that we inspire is not enriched of carbon dioxide. To test if this device was efficacious or not, he buried again 12 volunteers under the snow in a sitting position. And yes, the test was interrupted when the saturation dropped again below 84%. And here are the data that he showed. On the upper panel, there is the peripheral oxygen saturation. On the lower panel, there is the entitled CO2. And you can see that people who are using the device, the black one, could breathe up to the end of the test, 60 minutes, without having a significant oxygen desaturation. But the one who were not using the device, or let's say that was using the sham device, were desaturating quickly, and they reached the saturation endpoint that was 84% in less than 15 minutes. And again, we see that there was almost no increase or not significant increase in entitled CO2 in the intervention group. Instead, in the sham group, there was this very quick increase. So this study shows us the importance of carbon dioxide for survival in an avalanche, so the negative effect that the carbon dioxide has. And more recently, some Norwegian colleagues, a group of Øyvind Thomassen, made also another very elegant study. They create another model of, let's say, avalanche burial. So they didn't bury completely the person. They put just the head inside an artificial snow avalanche. The cavity has a volume of around 4.6 liter. The volume is quite important. If it's too small, we can't do the test enough. If it's too big, we have to keep the test too much long, and probably the people get cold and we have to onboard it. So we always to find the right compromise during this test. And he created two groups. In the intervention group, he was given a small flow of ambient air, not oxygen, ambient air at only 2 liters per minute, very few, okay? And in the other group, no. And you see the intervention group is the blue line. There was no decrease in peripheral oxygen saturation and no decrease in the tissue oxygen saturation measured with the NIRS device compared to the other group where there was a drop. So this means that a small flux of air can have a big impact. I heard Mark before was during the lesson say that the person who survived longer in an avalanche was a Canadian tourist in Italy in 1964 in Macugnaga. And probably these people was just next to a big rock on the ground, and probably there was some airflow. Based on this comes up our latest research. So some Norwegian engineers put together all the elements that was come out in the year and their passion for ski touring, but also their capability like engineer, and create a device, this SafeBake SBX, that when it's activated, it take the air from the back and then it draws around the face of the patient. And they say with a flow of 150 liters, so much, much higher of what was done in the study of Øyvind, of the Norwegian colleagues. And they say that with this device, they claim a person can survive up to 90 minutes in the snow. So they asked to us to test this device, and we say, yes, we can test it independently, but we will publish the result even if they are negative. And this is a very hard decision for a company who has invested a lot of money to develop a device, patent it, and test. But they accept, because they say, really, we want that our device really work for true. So we design a study, an interventional crossover randomized trial. We recruit healthy participants aged between 18 to 60, classified as a one, so healthy people, because for sure for also ethical reason, we didn't want that happen anything during the trial. And we exclude every person who has an acute disease the day of the test, but also we use some questionnaire to exclude claustrophobia, because in some previous tests that we have done, we see that claustrophobia can be a big bias. A lot of people are, when they are critically buried in the experimental setting, then they want to be taken out because they have fear. So this allowed us a more homogeneous sample. We have to recruit, maybe the number are a bit small, but 120 people, okay, to get these 49 people who were eligible. We randomized 36 participants in two groups. One group would have used the device, and one group would have used the sham device. So fake device were not working or pumping the air. And we do also a small modification of the protocol in the group, in the intervention group. When we reach the end point that was set at after 45 minutes of burial, that was when the curve dropped, we decide also to switch off the device to see really if the device, if there was a leakage, and if the effect of the long burial was really due to the device. So, yeah, the primary outcome of the study, that is always important when we set a study, was the time to oxygen saturation as measured by pulse oximetry during 45 minutes of monitoring, comparing the two groups. And like secondary outcome, we included also the measure of the gas in the snow, but also in the concentration at different distance, but also respiratory and cardiovascular parameter. So when we design a study, there is a lot of work before burying the people in the snow. We have to characterize them from a physiological way, and this we have done in a safe environment. We also try in this test also to make to understand them that to desaturate to 75%, that seems very low, is not so dangerous if you are healthy. If you climb Mont Blanc, you will expose to the same concentration of oxygen And so everyone performed a Richelieu test, so an hypoxic stress test before the test. So everyone was more quiet before the test. And then we have to prepare them. We have to isolate from cold. We have to assure that all the devices work and we could have a good measurement. And we have to be sure that we could communicate to the person for safety. This is very important in the mind of the person, because when you are fully buried by snow, you can't move. You have to trust. So the person have a radio, maybe you can see a bit here, and through the radio, with a headphone, they could hear our command, and they know that they could ask for help. They have a rope attached to the hand where they can shake and move a probe to ask for help, to be unburied. And plus they have, for sure, oxygen near the face that we could open in case of emergency. And all people well buried, as you can see, more than 50 centimeter depth. The snow was pretty high during the test day, was more than 500 kilogram per cubic meter. And we take in a very precise way all the parameters. This is Jürg Schweitzer, that is the head of the SLF Institute of Davos, the major institution to understand the snow characteristic. And this was a bit the setting, preparing the person. We put in a prone position, that is the most common position when we find a completely avalanche-buried patient, and then put the snow and then start the monitoring until the endpoint or until the participant asks. And you see we measure several parameters, mostly in a non-invasive way, but we also measure the gas concentration at different distance in the snow. So overall we recruit 24 participants, median age 28, and as said, the snow density was pretty high, but there was no difference between the two groups. So they were very comparable, both in snow parameter, but also physiologic parameter. As you can see here, we have a good representation of gender. In the new study, even in mountain medicine now, is quite appreciated if we find a good balance between women and men. And actually, we have almost a perfect balance in our study. And here is the main result. These are the Kaplan-Meier curve. So they show in the y-axis the cumulative risk of failure, so to stop the test. And on the x-axis, the time of the test, with the endpoint was 45 minutes. And you see that in the control group, almost almost 70% of the people stop the test between 10 and 15 minutes. Instead, all apart one in the intervention group stopped the test. And the only one who stopped the test was not for dyspnea, was not for desaturation, was because he has some pain due to the position in the arm, and so we have to unbury it, otherwise she would have finished it. And these are the parameters that are quite surprising. So in orange you can see the intervention group, so the one with the device, and in gray and black you can see the control group. So you see that there was no variation in the level of peripheral oxygen, there was no variation in the level of tissue oxygen saturation at cerebral level, and also the entire CO2 remained very stable. It means that was very, very tolerable situation, and instead in the other group you see it was very, very different. This was similar also for the ventilation parameter. I just take the minute ventilation. You see that the minute ventilation was perfectly stable all the time, but in the other group it increased a lot. It was a big effort when you don't have the device. And also, if we see cardiovascular parameter, let's take for simplicity the heart rate. You see that the heart rate actually decreased. There was some, for sure, emotion before being buried. and then it stayed very low all the time in the intervention group, but it increased, so there was quite some stress and physical effort actually to breathe under the snow without the device. It was also very interesting to see the behavior of the gas in the snow. The blue line is the control group, again the orange one is the intervention group, and you see that the oxygen level remain very stable near in the air pocket, and also the carbon dioxide, but they increase and decrease respectively quickly in the control group. And you can see that at a distance, when the device was activated, there was a progressive, let's say, increase of oxygen and also of carbon dioxide, and a progressive decrease of oxygen. This means that really the gases was spreading around, and we see that this happens at least at until 50 centimeters. That was the place where the probe that was put more far from the face was placed. And I want to close this study just to show also with the importance to have always this switch off phase in the intervention group. So you can see the red line is, so the blue line is the control behavior of people who has to stop, who are breathing with in the sham device, so the cumulative risk of termination. And when we switch off the device in the intervention group, the red line, it perfectly overlaps. This means really that the effect is of the device in itself. There was no leakage at all, and this I think also allowed us to convince the JAMA editor, that is, as you know, the third or fourth most important medical journal, to accept this paper. And I think he was also convinced by the fact that this mechanism is very elegant, and we really open new perspective for the rescue. Why we open new perspective? Because if the people can have a so stable physiological status for 45 minutes and they don't suffocate, we give more time to the companion to find them and to unbury them. And maybe in this time also the organized rescue can arrive. So if this device would spread, probably we can really have a big impact in the survival of critically buried avalanche victim who didn't sustain trauma, because there is also the other side of the medal, and who has still patent airway, because this device doesn't guarantee protection of the airway. Okay, so let's go to close a bit this first part, going to see what happens when we are here. We are above 60 minutes and we start to get cold, okay? To do study with hypothermia, we can't use human beings. It's not ethical to cool down a person below 45 degrees. So we need to use animal model, and we usually use pigs because they have a thermoregulation system quite similar to humans. This can be problematic, but I don't want to talk about the ethical problem of performing this study. This can be a challenge, but some time is needed. This was the first study that we have performed in 2010 with the colleagues of Innsbruck Medical University, just when Herman and me opened the institute. So we were in the Otztal. It's a valley in the border with Italy, but is in Austria. We create this artificial avalanche. We create a field operation theater where pigs were instrumented with all the device and when intubated, but left in spontaneous breathing. Then we bring the pigs here, and then we buried. And we create two groups. One group with an air pocket open to outside, and one group covered to inside. And what we see is that the group who has an open air pocket, who has so enough gas exchange, has a continuous drop of the temperature. Instead, in the other group, the core temperature stopped. And why it stopped? It stopped because there was a cardiac failure. You see that the cardiac output stays stable in the group of pigs breathing with an open air pocket, but drop in the other group. And this is well reflected by the arterial value of oxygen that was stable in the one with the open air pocket, and of carbon dioxide that was stable compared to the other one. So this study allowed us to show what happens even in the hypothermic or in the long burial person from a cardiovascular perspective. But we still need to know what happens to what we are most interested when we bring a person to the hospital. What happened to the brain? When some people survive without neurological damage and other no. Is enough the hypothermia developed to protect the brain or not, even in a completely buried avalanche victim? So to do this, again, we decide to use the pigs, because also the brain, the anatomy of the brain is quite comparable to the humans. When we set up an experimental study, we have always to consider all these parameters. We took 9 pigs that are and then we anesthetize them. We have to choose the right anesthetic, and then we cool down, keeping them with a ventilated volume control ventilation. And at the same time, we instrumented the pig. So we put a pigtail catheter in the transverse sinum in the brain to collect cerebral venous blood sample, and this because it reflects the usage of oxygen in the brain. And then we put an intracranial pressure probe in the brain to measure the intracranial pressure. So this was a bit the setup. So the pigs were anesthetized, so they didn't suffer. For sure, in our test, we try to use as less as pig as possible, and we have to develop also here an experimental model. So we decide to cool down the pigs to 28 degrees. This was not written everywhere. We have to do several tests to reach this temperature. Then after 20 minutes, we decrease the inspire fraction of oxygen to 70%. And then after other 20 minutes, we take out the scrubber of the ventilator to catch the carbon dioxide, and then the level of carbon dioxide increase. The end point was when the pigs become unstable, or after 60 minutes in the latest phase. And actually our work, if we see the level of the arterial level of carbon dioxide and the oxygen saturation was efficacious. We can see that during the test we confirm this decrease of cardiac output that we see in the previous study in the field. And overall, just to summarize quickly, so the blue line was the hypothermia phase, the red line is the hypoxia phase, and the yellow part is the carbon dioxide phase, where we have this combination of the 3 parameters. We see that when we cool down the pigs, for sure, we have a decrease of cerebral perfusion pressure, and we have an increase in the cerebral venous saturation, because the metabolism low down in a hypothermic patient, so we use less oxygen. This can be compensated during moderate hypoxia, so breathing inspired fraction of oxygen 17%. But when start increasing the carbon dioxide, we have an increase in intracranial pressure, we have a big drop in peripheral oxygen, in the perfusion, in cerebral perfusion pressure, and we have a big drop in the cerebral venous oxygen saturation. This means that there is a disbalance, and this is mostly due to hemodynamic. And this explains a bit why critically buried avalanche patients who are prolonged for a long time still have a bad prognosis compared to purely hypothermic patient. So overall, from this study, you see how many models we use. We get interesting result to understand well what happens to the body and how to manage better the patient. But I don't want to go in this in this part, I will leave to Herman. I will only close saying that when we have to rescue a patient from short time, our problem, we see from my pathophysiological side, is an asphyxia problem. When we have to rescue a patient for a long time, the main problem is hypothermia, but it's not pure hypothermia. It's always a combination of hypoxia and hypercapnia. Thank you very much.
Thank you very much. As you can see, you can understand every sentence in your English. Thank you. Is there any question? The Jungs? Physiology is it's recent for you.
Maybe just one comment. Thank you very much. That was very interesting and you explained very well the physiological parameter of the patient under an avalanche. What do you think about the device that we are going to need to practice mountain in the future? Because you need the airbag, you need the device to breathe if you are buried, the device to search the pulse. So that's a lot of things. Is it heavy, the new device that you tried this with your last study in the JAMA? It's
A SafeBack device is extremely light, so this also could be a win-win combination because it's not as heavy as an airbag. Probably is 500, 700 grams. So it's something that one could always have, like everyone should always have the transceiver. For sure, what I say, to have the device is not something that substitutes prevention. This we have always to say. But for example, these devices are very important, for example, also for who practice rescue and emergency medicine and intervene in avalanche accident, because we are always exposed to an increased danger when we are in the field. So how we can increment the level, our level of safety. So this could be an option.
Okay. And one other question. Do you think the device, if you go to hypothermia, do you think the device can also prevent the hypercapnia because of the airway that it creates, or if you go for a much longer time?
Yeah, but the battery of the device in itself works more than 90 minutes, so they certify till 90, but probably continues working, and we see that the amount of flow that it gives is very, very high. So it's why I think it's nice to show the previous study, this basic study that was done by Ovid, giving only 2 liters of oxygen and see the impact that of ambient air, the impact that it has, and also a device that flush 150 liters. Allowed us also to think that even if the efficiency of the device decrease in the time, probably some effect will remain. But for example, this open new question. So this show that we have to do several research. Every time we add something, we could do several other investigation, no? And it would be also nice if different groups perform as we have done, for example, with the artificial air pocket device of Grissom, because you can see if the different model brings to the same result.
Hello. Do you know of any studies that are looking into automated triggering for airbags? And for that, one of the main challenges is that it's impossible to actually trigger. It's really rare to be able to trigger.
Okay.
Is there anything that is happening in studying the same way we see airbags in motorcycles that are automated triggered?
Yeah. Let's say that automatic triggering is not a new concept. Already in avalanche backpack, there was some tentative of Bluetooth activation. So there are some devices who can be activated. So the technology is not so complex. But sometimes, maybe with this device could be very good because it doesn't harm. But for example, for an avalanche backpack, in some situation, I was crossing today passing near La Grave, for example. I don't know if I would like that my airbag open sometime in some places over there. So we have always to think maybe where we want to open, no? So this, we have to consider also this, if it opens really in the right situation. But it's possible.
Giacomo, thank you for your presentation. It was very good. How difficult and how long does it take to get the ethical approval for this kind of physiological studies? Thank you.
No, thank you, Mark. So I have to say that we work for STEP. Probably we get a very good, I would call a relationship or trust, let's say better, with our ethics committee. So to obtain the approval of this, this was normal. I think in 2 months we get it. I was very surprised, I have also to say, but they didn't say. But the key is also maybe to have a member inside the ethical board who understand the topic, maybe so to have a emergency physician, anesthesiologist inside who can maybe revise and understand the level of danger. I have to say that safety was the most important things to take care for the participant of the study. You feel very responsible. And on the other side, I have to say that I were very confident that everything would have worked. Because having a prone position, for example, the snow can go in the mouth, even if you have some salivation, other stuff. This shouldn't obstruct the airway. We have oxygen that we have a pump that you open and then it arrives. And also to unbar it from 50 centimeters where you know where is the person is very quick. Also because the most important thing is just to create a passage of air from inside to outside. So you want to keep, then for sure the reviewer asks, well, why you didn't bury the 1 meter depth? No, that is the medium, the average depth level, but you have to explain to them that maybe there are some safety concerns for that.
I have a question. Did you study the impact of the effort before to be buried? Because when you ski, your cardiac output is quite high. And during your study, patients were at rest.
Yeah, this is an interesting topic. I believe that with this level, this amount of air, even if you have a quite physical effort and quite high production of carbon dioxide, I think this is still acceptable. We have to think that we tested in very bad condition. The snow was extremely dense. No, so it was the worst condition in terms also of accumulation of carbon dioxide. And still the device was working very well. But again, I think these are always good observations. This is, when you do a study of this, is only a starting point. For example, one thing that we didn't test was the effect of the weight of the snow on the thorax. Because for sure we couldn't pack the person like it's in a real avalanche. You know? And we can't evaluate, for example, the effect of trauma on what we observe. So this means that every time we do something experimental, the next phase is just to maybe push that the people use it, but also monitor. So and then we will evaluate really if a device is efficacious or not. People maybe don't activate, people maybe when we have a chest drum doesn't work, but still it will work for someone. I have just a small note, maybe, oh yeah, just.
Je m'excuse, je vais la poser en français la question. Tu as repris des données, je pense, de l'étude qui était faite par Avalanche, Black Diamond. Sur les deux groupes où ils avaient des systèmes d'avalanche, justement, avec une expiration de CO2 dans le dos et puis une expiration de CO2 à distance. Je crois que c'est à peu près ça que tu as repris à un moment sur tes slides.
There was he was asking about the avalanche system, and you presented some data about the the avalanche system. That's something that also brings the oxygen you breathe and you expire in the back, and it's what is the question is quelle est la différence?
La question, c'est une remarque, mais donc en fait c'était intéressant cette étude-là, c'est que c'est contre-intuitif, mais ça tendait à prouver que la poche d'air n'était en fait qu'une capacité d'expiration de ton CO2, et plus elle est grande, moins tu vas rebriefer ton CO2. Mais la question, c'était finalement la conclusion de l'étude sur cet aspect physiologique était vachement intéressante, mais par contre, il n'y avait aucune appréciation possible des défauts d'ampliation, si tu veux, qui sont dans les contraintes mécaniques dans l'ensevelissement. Et je dis, est-ce qu'il a une idée de ce phénomène-là qui est peut-être aussi important que les troubles physiologiques d'échange gazeux?
Okay, I'll try to translate. Okay, so it's saying that the avalanche device was able to show that the importance of the expiration of the CO2 inside the air pocket, and but he's asking if we have some data about the other factors that are impacting the ventilation, the compression, and the thorax constraints that can happen.
Yeah, I think you are perfectly right. Unfortunately, this other factor we didn't measure the effect of the snow. We didn't in this case. We choose just to see these parameters. Sometimes when you design a study, you need just to have a clear question and try to answer. But then this open, now that we see that it works, a lot of other questions, and we still have some additional ideas maybe to how to test this additional question. Weight of the snow, compression of the thorax, for example. But for example, as soon as we see that this works, then we can also develop the other question. If we would have mixed too many things, probably we wouldn't have we wouldn't have been capable to give a clear answer to say, okay, this carbon dioxide removal, or probably also the increase of bringing oxygen to the air pocket, because also there we should see has a big impact. And for sure, what I say, also looking the participant after the study, this works very well. They were staying with the device, and they say they could stay very long. And I remember previous study in the Avalanche, where maybe you have more depth space, maybe the inspiratory effort is bigger. For them, it was much more stressful, at least in a supine or a position, because Grissom do in a sitting position that is much different also in that sense. So this just shows how many detail we have to think when we design this study. And for sure, then we see what happens in the real world.
We have a forensic doctor with us, and maybe forensic science is are better with positional asphyxia or trauma asphyxia than physiologists or doctor, because such patients always die. So probably, I don't know what's your mind on this topic.
Hello, thank you for your interesting presentation. Yes, we have some criteria in autopsy to assess asphyxia. For example, edema, pulmonary edema, cyanosis, and also the complementary exams after with histologia and also post-mortem scans, which are also very important to qualify asphyxia. Yes, I don't know if it's the good answer to the question.
I also, if I can say, I agree, it's very important to see that in a real world, and also maybe to have an autopsy of this victim, to understand why they really died. Because I remember also today, I don't know if it was Mark or Francois who else, showing the data, but most of the time outside we think we don't see anything. We think that the person has no trauma inside, and only with autopsy or after medical examination we see all this lesion. So this is quite important to on, and this is a nice bridge with experimental research. So experimental and clinical has to go together and compensate each other.
The last question of Vivien.
Yes, thank you for your presentation. Two small questions. Do you have a real picture of the device first? And the second question, did you study the impact of the distance between the mouse and the device? If I good understood, it is not into the mouse, but in front of the mouse.
Okay. Okay. Yes. So yeah. I don't know if I have a connection, but I can show. This is, yeah, I can easily, I can then find maybe you a picture, but the device mostly is just inserted in the backpack. So in the back there is the device, and then you have a two small tube on the, how do you say, on the shoulder of the backpack, okay? And they start from the shoulder down here, more or less where you have most of the T-shape things of the avalanche back of the airbag. Similar, very, very similar. In the two sides, they have a mesh to prevent the snow to close the device, the exit. So mostly, the distance more or less was 10-15 minutes, 10-15 centimeter from the mouth and the nose. I didn't go in detail looking all the gas data, but we also measure the concentration here and on the mouth, and then of 25 and then a 50 centimeter, and more or less the efficacy was very good in all these points. So we think that even if it's 5 or 10 centimeter from the airway, doesn't change so much, and the air can really pass even if there is some snow. Having 2 points also allowed that even if it's one is compressed by the snow, then probably the other works, and the efficiency is very high. So I think, if I remember well, because it was one of the answers that the reviewer of JAM asked to us was, and the company give us their test, and they say that even if both the part are reduced in diameter of 50%, still the efficiency is above 70-80%. So has a flow, if we think it's 150 liter, compared also to the previous studies of WIC, that is more than enough to deliver enough fresh air and to remove carbon dioxide. Okay, thank you again. And now let's go to Bolzano. Herman, do you hear us?
Yes, I hear you.
Oh.
Do you hear me?
Fine, fine. So
okay, great.
Let's go in the past for some history of your work. And after the speech of Herman, we have a little surprise for you. It's up to you. Let's go.
Okay. So thank you. Good evening to everybody. And I'm very happy to be with you this evening. And thank you so much for the invitation. I'm really I apologize that I cannot be there in person, but it was not possible to put it into my schedule in the calendar in a short time, and to be back in time on Tuesday. Okay, so thank you, Giacomo, for giving us an overview about experimental research. And I would like to go more into epidemiological data and also clinical examples and the algorithms and treatment recommendations that are currently recommended. So I will try to share my screen. Can you see the screen?
Yes, Herman. And if you want, it will be easier without the camera because of the stream.
Okay. Can you hear me and see the screen?
Yes.
Perfect. So I will try to split my presentation into 3 parts and start and begin with a retrospective view on the last 30 years of avalanche survival and how it developed in the last 3-4 decades. Then I pass on to the current guidelines for field treatment, and would like to finish with some clinical cases that have a specific direction to future development of the recommendations. So if we look back to the last 40 years, in 1994, we calculated the first survival function using Swiss data, the only available precise data that time, and we published this on Nature. And the result of this first avalanche survival curve was that the survival phase, surprisingly, was about 15 minutes. That means that within 15 minutes, the probability to be alive under an avalanche is higher than 90%. And this was a surprise for everybody and had just a big impact on the development of new search devices and also an impact on education and the behavior of ski tourers and off-piste skiers. Explain what this curve shows, we have to go a little bit into detail because it is not simply the probability of being rescued, but it is the probability of being alive under the avalanche in case of critical burial. That means if the head and the chest is under the surface of the snow. And we have to calculate this. This was not easy, and we used the so-called Turnbull algorithm for interval censored data. What does this mean? If you have an avalanche victim extricated from the snow in an avalanche, you have 2 possibilities. The first possibility would be that the victim is alive, and the second one would be the victim is dead at the time of extrication. But in the case of a victim who is alive, you do not know how long the victim would have been alive if the victim wouldn't have been rescued at a certain time point of the burial. And on the other side, if the patient is dead at extrication, you do not know at which time point before extrication the patient died. So this is called left censored, and the other case is right censored. And this is the tricky point of a calculation of survival and the probability of being alive in the avalanche. And therefore, I would like to explain this because this is a very important point when we compare this curve with other curves published in the past years. So the result of this calculation was that, as I said, there is a survival phase. We recalculated the curve years after and published it in Resuscitation 2001. And the survival phase was in both studies between 15 and 18 minutes. So 15 and 18 minutes is a time window to find an avalanche victim, probably alive. After that, there is a steep drop of the survival probability from 90 to 35%, which is the real drama of the avalanche, because in this short time span of 20 minutes, 2/3 of the avalanche victims die if they are completely buried, if they are critically buried. And this we call the asphyxia phase. But then there is a rather flat period of the curve. That means that not very much happens if the victim has survived longer than 35 minutes. And this is the so-called latent phase, where the victim can breathe and goes into hypoxia and hypercapnia, but slowly develops also hypothermia. And there is a small portion of survivors who can survive very long. And as I heard, Mark has already mentioned the longest survival of a complete burial in the Lombardy region of more than 30 hours in the 1970s. But we have quite a few cases where the survival exceeds 3, 4, and 5 months. And in our last epidemiological study, we put ourselves the question, has avalanche survival changed in the last 30 years? That's a quite interesting question, because the data we used in the last studies are rather old, and there happened a lot of research, a lot of therapeutic initiatives, etc. And so maybe the curve has changed. It is a cohort study on critical avalanche burials, again from Switzerland, to have a homogeneous data set. And we compared this new data from 1981 to 1990, from 1981 to 2020, to the old data from Nature from the period 1981 to 1990. Altogether, there were over 7,000 persons involved. So in this case, we can say we have a good sample. It's not only a few hundred, but it's 7,000. And we extracted from them the victims in buildings and vehicles to have a real picture of those recreative avalanches we encounter as rescue doctors in most times, in most cases. And we included altogether 1,643 critically buried out of 6,900 in free areas. That means that of all involved persons in an avalanche, 24% were critically buried. So one quarter of the avalanche victims is critically buried. 3/4 usually are unburied or partially buried. And this is the result. You see here a orange line and a dark blue line. And the dark blue line is the new line, and the orange line was the line of the nature sample of between 1981 and 1990. And you see there is a period where there is almost no difference. So between 20 and 90 minutes or 120 minutes after burial, they are overlapping. There is nothing new. But there is a period at the beginning and at the end of burial where we have quite significant differences. First of all, in the so-called survival phase, and in a new curve, the survival probability remained above 90%, but only during the first 10 minutes burial. And then it decreased to 30% between 10 and 30 minutes. So this is the 30 minutes as a threshold for survival without open airway and air pocket remains the same. This threshold is not changed, but the survival phase is shorter than previously assumed. And the second key difference applies to the long burials. And we see that longer than 130 minutes burial, there are quite a lot of survivals. And the percentage increased from 2.6 to 7.3%. That means this is quite a good result, and it means that maybe also the medical treatment has improved, and all those measures by the organized rescue teams has a very, very, I think, are efficient. Here you see the second curve, and this is in contrast to the probability of survival. This is the survival rate. That means how many victims survive out of 100 persons. So the percentage of survivors over the decades from 1980 to 2020. And here you see the time points, then 3 years averages. This is the black line, and the blue dashed line shows the decades. And here there is a movement. And interestingly, we have a very flat development in the 1980s, then a step up in the 1990s, and then no movement or no change, no significant change anymore since the turn of the millennium. And altogether, the survival rates of critically buried victims increased from 43 to 53 by 10% in this period of observation. Interestingly, only in one decade. It is in the decade of the 1990s, and we do not exactly know why this was just there during 1990 and 2000. Might be more information about the survival phase, the 15 minutes at that time from nature. Might be a development of the technical equipment, so the transceivers, who were equipped with 2 and 3 antennas in this period. This might have changed the survival rate and increased and lowered mortality rates. And the survival rate for victims rescued by companions improved from 68 to 74%, and survival rate for victims rescued by organized rescue teams increased from 14 to 22%. We have calculated also the probability of rescue by rescue type. That means the probability of being rescued over time. And this is also quite interesting because you see here 2 groups. The first group are victims rescued by companions. And the second group is the group rescued by professional rescue. Each group has 4 curves, 4 lines, which represent decades. And the lowest line is the oldest decade, and the blue and the black lines, they are the newest lines, so the last 2 decades. And you see that over time, from the first decade to the last 2 decades, the median rescue time or burial duration has decreased in both groups, more in the organized rescue group compared to the companion group. Let's go into the details. So in average, the median rescue time decreased from 45 to 25 minutes. This is a very good result for everybody. And the median rescue time for victims rescued by companions decreased from 15 to 10 minutes. So from 15 to 10 minutes doesn't look very much, but it makes a great difference, because we have seen that the inflection point of the survival curve is exactly at the 10 minutes. But this is by chance. This is you have to think that the median is exactly the midline of the population. That means that at 10 minutes, half of the population observed has been rescued within the 10 minutes, and 50% of the population has been rescued after the 10 minutes. So 10 minutes is the median, and this has to be considered. It's not the maximum. And the median rescue time for victims rescued by organized services has been decreased by more than 60 minutes. That means that this has decreased significantly, and this is a very nice, in my mind, a very nice result. That means that the organized rescue teams, they are much faster. This might have to do with phone connections and a very fast alert that has not been so popular and reachable in the 1980s and 90s. But the rescue services, they are really very, very fast right now. If we look at by rescue type and the survival rates, then we see that the victims rescued by companions had almost 3-fold higher chances of survival compared with those rescued by organized rescue teams. That means the relative risk is 2.9 in numbers, the survival rates by companion rescue are 74 compared to 22 for rescues by organized rescue services. So this is an important result for all the skiers and ski tours and off-piste skiers, because companion rescue is much better than organized rescue services in terms of survival. So if we discuss these results, we can see that the increased survival rate is definitely primarily due to the reduction in rescue time. We have both. We have a reduction in rescue time and we have an increase in survival rate, and this at the same time. So probably the increased survival rate is exclusively due to the reduction in rescue time. And this is attributable to technical improvements of the safety devices, which are much preciser than previously, better education and training of winter sport enthusiasts. That means that all the initiatives to educate, to train, and also the initiatives to improve technical equipment, they have been successful in the last decades. So the avalanche transceiver, for instance, is a very, very efficient, effective instrument for search and for rescue avalanche victims who have no sign on the surface of the avalanche. And in an older study, we found a reduction in mortality from 71 to 55% in critically buried victims. The second main result of this study is the shift in the inflection point of the survival curve from 15 to 10 minutes. Why? Why did this? Has this been reduced, the survival phase? This could be theoretically attributed to an increase in severe trauma, or second possibility, an earlier onset of asphyxia. We know from a study in Canada that Giacomo has already presented before, that there is a difference in the continental climate zones versus the maritime climate zones in the curve of the survival, where we have less dense snow. The curve is similar to the Swiss one, where we have a very high density snow, then the curve is much steeper. But there was the question whether this difference is also due to trauma fatalities. But in this study, the Canadian study, and the comparison to the Swiss survival curve, we have extracted trauma cases from the steep curve sample from the Canadian sample, and we have seen there is no difference. So the trauma is very unlikely to be the cause of this shift of the inflection point to 10 minutes in the last years. And is it really true that the snow density has increased in the last years? Many think that one may think that it is due to the climate change, and with higher snow densities, the inflection point moves forward. But we have no strong evidence to support this hypothesis, because we need the simultaneous measurement of the snow density at the site of the accident when the victim is extricated, and these data we don't have. So at the moment, it is a hypothesis. Could be that the climate change has changed also the survival curve, but we are absolutely not sure about that. But anyway, in any case, the short time window of 10 minutes is quite important for a successful rescue and should be considered by all rescuers and manufacturers for safety equipment. And it shows that asphyxia remains the leading cause of death from avalanches. So summarizing this last study, we have a good news. Avalanche survival rates are increasing, while median rescue time are decreasing, and the long-term survival rate has improved. The bad news is that asphyxia begins earlier than previously assumed. The cause of death has already been mentioned by Giacomo, and there are only a few autopsies in the world of avalanche victims, most of them in Canada and the United States. In Europe, it is very rare that avalanche victims' fatalities are autopsied, are opened by a pathologist. And in a review, we found that only a very, very seldom, in seldom cases, hypothermia is the only cause of death. And this is exactly what Giacomo said. Hypothermia alone is almost never the cause of death in an avalanche. It's always mixed and combined with trauma or with asphyxia. And asphyxia remains the main cause of death, with about 80% of all avalanche fatalities, followed by trauma with about 13%. This belongs to Canada and the United States, but I guess in Europe it won't be much different. If you look at the survival rates of avalanche victims who are unburied, extricated with cardiac arrest, in a hypothermic state, and rewarmed with extracorporeal rewarming, then we have to say that the overall survival rate is quite low. Survivors, 12% of all the rewarmed hypothermic avalanche victims survive, and this is low compared to all-cause hypothermia, hypothermia from exposure, and even hypothermia from drowning. So this is the lowest percentage in all hypothermia cases in the avalanche. And this is because asphyxia is always combined with hypothermia. Let's go to the next part of this presentation, the current guidelines for field treatment. There are a lot of guidelines proposed in the past 40 years, since 1996. I was involved in all of them, from the first to the last. And if I remember, the first one was developed or proposed by Bruno Dürer and me in a meeting of ICAR-MEDCOM in Switzerland. And then there was a series of developments of the algorithms, and we tried to make the best out of them. But numbers are extremely low, and evidence is hardly reached. So we have to take them with great care, because, as I said, the evidence is rather low because of the low numbers. We have hypothermia numbers of 100 per year documented in the literature over a period of 20, 30 years. So this is compared to normothermic cardiac arrest of 100,000 per year in Europe. So it's rather difficult to reach a higher level of evidence in avalanche. The last ones were the ICAR-MEDCOM recommendation of 2023, and the last one are the ERC guidelines 2025. All algorithms have the same question. When shall we start with the cardiopulmonary resuscitation in an avalanche victim, and which patient should be transported to extracorporeal rewarming? And these two questions remain always the same over the decades and through all the algorithms. The last one, as I said, were the guidelines, ERC guidelines 2025. And with this algorithm, unfortunately, the algorithm has a little bug, and there are two unknowns decisive errors of equal or more of 30 centigrade or unknown, and we have the same lower than 30 centigrade or unknown. So this is a bug, should be corrected. In my mind, it's an important detail, but okay, we have to live with it right now. So I would like to explain the ICAR-MEDCOM guidelines, who are really the most sophisticated recommendations, because it was a great review done by Mathieu Basquier, and together with Giacomo and a group of ICAR-MEDCOM members, and the result is really, I think, the best we have at the moment. And for the first time, the algorithms have split it into two. We have a first algorithm for the first responder, so BLS trained responders, and a second algorithm for the ALS trained physician or paramedic. And these are two parts of the same sheet, and also part of the checklists that are in use in the alpine regions, developed by Alex Kottmann and Swiss colleagues. So let's start. Okay, you cannot see the upper part. Oh, yes. So this is the first algorithm, and you start, of course, assessing the airway patency and then the duration of burial. And if there are vital signs present, you can use all those recommendations, or you follow the recommendations in the green box down of this algorithm. That means that if there are signs of life, the situation is not so critical, and you begin with ECG and core temperature monitoring, handle the patient most gently and treat hypothermia. Consider hospital with extracorporeal rewarming if the core temperature is lower than 30 centigrades. And you see on the ECG a ventricular arrhythmia or a systolic blood pressure measured lower than 90 millimeters mercury. In this case, the patient usually is not in a great danger. If there are no signs of life, then it depends on the duration of burial. And if the burial duration is up to 1 hour, so equal or less of 60 minutes, then a critical patient is critical due to asphyxia. And you should start with 5 rescue breaths. And if the time is longer than 60 minutes, the patient is probably hypothermic. And if there are no vital signs present, then you should start CPR. And in the only case, if the duration of burial is longer than 60 minutes and the airway is completely obstructed, and you see an asystole on the ECG, then you can stop the all resuscitative measures on site. Measure the esophageal temperature as soon as possible, and then you pass on to the algorithm number 2, the ALS treatment. You follow the steps. If there are lethal injuries, you can discontinue CPR or not start CPR even. If the duration of burial is less than 60 minutes and there are no lethal injuries, measure the esophageal temperature. And if the esophageal temperature is higher than 30 centigrades, then you can consider termination of CPR if there is no ROSC during the ALS treatment after 20 minutes. This is the general recommendation for a short burial. Short burial, suspect asphyxia, and start advanced life support at least 20 minutes. So these hasn't changed in the last recommendations. If the burial time exceeds 60 minutes, then the situation is different and you have to suspect hypothermia. And you see, the algorithm is rather complicated, but there is one main rule. If there is any electrical activity on the ECG, don't give up the hope and start and continue CPR until the transport to ECLS. If there is any vital function or any electrical activity, don't give up hope, because those patients may have a good prognosis. If there is an asystole on the ECG, if it is witnessed, then you should go to a hospital with extracorporeal resuscitation, measuring the esophageal temperature. If it is not witnessed, then depends on the airway. And if the airway is patent, again, start CPR, and go towards the hospital with ECLS. If the esophageal temperature results higher than 30 centigrades, then it is clear that it is not a hypothermic cardiac arrest, and you may consider the termination of CPR if no risk is reachable after 20 minutes. If the airway is obstructed and the duration of burial exceeds 60 minutes, then you can terminate CPR. So in a few words, burial longer than 60 minutes and no vital sign, any cardiac activity should lead to CPR and ECC rewarming. If there is a ventricular fibrillation, we recommend up to 3 shocks, but this is the difference to a normothermic cardiac arrest. If there is no success, you should not give up and continue CPR and go to a extracorporeal rewarming. If there is a burial longer than 60 minutes and the airway is patent, but on the ECG there is an asystole, then also, again, you should continue CPR and go for extracorporeal rewarming. Arrived at the hospital in these cases, there we have a new method to estimate the prognosis of a hypothermic patient, including also avalanche patients. And it is the hypothermia outcome prediction after ECLS, HOPE score, presented and proposed by Mathieu Pasquier. And this, I think, is the best way to estimate the prognosis nowadays, and should be used at hospital arrival. And the predictive markers from his study, and this study has been externally validated, so the HOPE score has a high level of evidence. The markers are age, sex, mechanism. The mechanism includes asphyxia or not asphyxia. Asphyxia means any avalanche critical burial with blocked airway. Non-asphyxia includes avalanche victims with an air bucket and free airway. Then duration of CPR, core temperature, and potassium. Interestingly, the witness of cardiac arrest and the first cardiac rhythm did not result as predictive. You find the HOPE score for the measurement estimate on internet, and it's easy to complete this protocol. And if the result is less than 10%, then there is a good reason to stop resuscitative measures in the hospital and not to resuscitate and rewarm the patient. But once the percentage is higher than 10%, a victim should be rewarmed in any case and resuscitated. In accordance to the algorithm, we have created also checklists for the documentation of the data, pre-hospital, out of hospital, and then for the use in hospital. So this is quite important to teach and to inform all the rescue teams to use these checklists, because the information from the from on site, from the avalanche site, to the hospital where the decision is taken to rewarm or not to warm should be authentic. So there should be a clear information about those data, more exemplary and important for the decision in hospital, for the rewarming decisions, and therefore the checklists are not only educative, but they are important for the data flow from the avalanche to the emergency room. Of course, for a long distance, for flights, and also for terrestrial rescue, the use of a mechanical chest compression devices is highly recommended because of the higher quality of chest compressions. So there are, to remember it better, I reduce the algorithms to 3 messages. If there is a cardiac arrest and the burial is short, that means up to 1 hour, there is no hypothermic cardiac arrest, and CPR and ALS should be performed for at least 20 minutes. If there is a cardiac arrest and the burial is long, that means longer than 1 hour, and the airway is free, then we should suspect hypothermia. We should not give up and continue continuous or intermittent CPR until extracorporeal rewarming, and use the HOPE score in hospital. And the third, the bad message is if there is on the ECG an asystole and the burial is longer than 60 minutes and the airway are definitely blocked, there is no hope. There is no CPR necessary, and we can declare the patient dead at the site of the accident from asphyxia. I come to the last block of my presentation, and would like to present you 3 clinical cases in my region, in the province of South Tyrol, which have give us a future direction for developments in the future of the algorithm. They are quite extraordinary, and I tell you why. So there was a first accident in 2023, 10th of January, in the Avalanche. It's in the Dolomites at 2,400 meters above sea level. It was very cold, -8 centigrades, with a wind speed of 30 kilometers per hour. And a police officer was ascending, and at 49 years old, and he was buried by an avalanche, and with a burial duration of 45 minutes. After 45 minutes, he was found in asystole. The airway was patent, and the core temperature esophageally. So during the intubation, they measured in the lower third of the esophagus 24.7 centigrades. And this has been confirmed at hospital arrival. So we had an extremely high cooling rate of 14 centigrades per hour. That means with this speed of cooling, this person would have reached 30 centigrades before the 60 minutes. So this is an example of a very rare high cooling rate, where we should be a bit careful in cases where it is very cold outside and it's windy, and the person is in ascent, for instance, sweating. That the time for being hypothermic can be shorter than 60 minutes. In this case, the patient has been provided with mechanical chest compression, and in hospital he had a serum potassium of 7.8. He was put on ECMO, defibrillated at 29 centigrades, had a return of spontaneous circulation, but he did not regain consciousness. And after 30 hours, he was weaned, and after 66 hours, he was declared dead from a brain death. Why is this so extraordinary? Because he became an organ donor, and he donated the lung, the liver, and the kidneys. This is not in the algorithm. So organ donation is an aspect, a new aspect in avalanche treatment, should be considered in my mind. In cases of short avalanche burial with cardiac arrest, and there is only one study about the use of organ donation in cardiac arrest patients from avalanche burial. And it's a Swiss study, and in this center, 11% of those avalanche patients became organ donators. But I think in the future we should think more about this positive aspect of a fatality when we are thinking about continuing CPR or stopping CPR at the scene. Maybe we should be more liberal, more thinking, positively thinking, if the resources allow it, to bring patients, even if the prognosis is bad, to hospital, maybe for a organ donation. Second case, the so-called ZAS avalanche. It was in February 23, again at 2,300 meters. A 53-year-old man was alone, and he was missed. He was found only the day after the accident because the rescue team did not know the exact location where he was moving in the mountains. And he was found 23 hours after the accident, after the fall of the avalanche, under 1 meter snow, completely buried. But he had one hand out of the snow. And this was this specific detail that made this case so interesting. So he was completely buried, hand out, no gloves, but the hand rescued himself because the helicopter flying over the avalanche has immediately seen this hand out of the snow, and he was rescued within a few minutes. He came to hospital. He was conscious, so I go back to say, okay, he was a Glasgow coma scale 11. In Glasgow scale was 11. Breathing had a peripheral pulse of 40-50 per minute and a core temperature of 23, which is very, very low for an avalanche victim. And very low, in contrast to the previous case, a very low cooling rate of 0.65. He was brought to hospital and externally rewarmed with forced air. And but immediately when he arrived, the big problem was not hypothermia, but was the severe frostbite on all fingers. And the combination of frostbite with severe hypothermia in an avalanche is extremely rare. It is described in literature only once. There's one other case that happened many years ago in Switzerland with a 17-year-old boy who lost the hand, but he had the same situation. He had the hand out of snow, and the treatment started 2 days after the accident, and maybe this was the reason why he lost the hand. So this patient was rewarmed, and as soon as they reached a core temperature of 34, started with frostbite treatment. And this is a multimodal treatment with a lot of drugs at the same time. So they gave him ibuprofen, enoxaparin, and thrombolysis with arterial alteplase, iloprost for vasodilation, and even made a sympathical lysis by axillary block for this patient to have the maximum of vasodilation for the treatment. And fortunately, this was successful, and the frostbite was reversible, and after a few months, he had still some neuropathic pain, but he did not lose any tissue and could have been discharged with no sequelae, no neurological sequelae with CPC1, and he had a full functional recovery of all fingers. He complained a slight hypersensitivity to cold below 14 centigrades, and a neuropathic pain treatment treated with pregabalin, but now even the pain resolved completely. So I show you this case because it's rare, but we should think also of a possible combination of hypothermia and frostbite. And the only pharmaceutical treatment of frostbite, which has a high level of evidence, we made a meta-analysis a few years ago, is iloprost and thrombolysis. And again, frostbite is not included in the algorithm, but it could be part of the treatment in an avalanche victim. And it should be initiated in a severely hypothermic patient as early as possible and not postponed by days. And now the last one, I think it's time to close. And I hope you're not too tired to listen to this last exciting case. It was a Racing avalanche last year. in February, 2 years ago, in February 2024, Leitner-Hochjoch, 2,400 meters, a group of 3 skiers in ascent, and all 3 were completely buried and were missed for 4 hours. After 4 hours burial, the air rescue service reached the place, and they found a very, very difficult situation. So they were all buried very deeply. The first victim was declared dead right after 4 hours of burial, airway blocked, asystole. The second victim was conscious, externally rewarmed in the closest hospital and completely recovered. But the most interesting case was the third one, and she was a woman. And was in a prone position, so on the belly, face down, patent airway, had some breath when the doctor reached the victim, and had a hypothermia, a severe hypothermia with 20.7 centigrade esophageally measured. The rescue doctor said that she was breathing for a moment, and when she turned the body on her back, she went into cardiac arrest and had an asystole. So after 4 hours, 3 meters deep, breathing in for an instant, then going into cardiac arrest, and on the monitor, the diagnosis was asystole. But when they printed out the ECG, they have seen that it was not exactly an asystole, it was a fine fibrillation, ventricular fibrillation. And this has been missed at the monitor, at the site of the avalanche. This should also be considered, So asystole can be suspected, but it is not 100% sure that it is not a fine wave fibrillation. The doctor did not give up, started mechanical CPR, and brought this patient to ECMO. She was rewarmed, had no neurological sequelae. So CPC 1, and was brought to her home hospital in Germany, and she completely survived. So this is a very, very nice case, showing that asystole should not be a contraindication for rewarming, even in an avalanche victim with long burial, even after 4 hours, no vital signs. But airway was patent. The negative point was the asystole, but nevertheless, the correct decision according to the algorithm saved her life. So the conclusion would be no hypothermic avalanche victim with a patent airway is dead until rewarmed and dead. Still valid. In conclusion, I would say the survival chain for avalanches is a bit different from that what we expect, because we are here, the ALS and the ECMO part, and these are the smaller part of this chain. We are not that successful. The most successful part is the first phase of the rescue, search and extrication. If companions are effective then they can save many, many lives. So companion rescue is key. Thank you very much.
So, is there any question?
Question. Thank you very much. Just there may be 2 time points in the algorithm that we can discuss, and that may be time to review. It's the 60 minutes. You show that sometimes some patients are cooling faster, and some patients may also benefit from organ donation, maybe within the 60-minute time point. So maybe it's 60 minutes should be dilated or shortened. And the other point is 30 degree. We know that usually in patients in good shape, there are no ventricular fibrillation or no cardiac arrest under between 28 and 30 degree, and the only patients that were in this between 28 and 30 were patients with comorbidities and other health problems that we do not encounter in mountain rescue most of the time. So maybe 28 is better than 30. I don't know.
Yes, there are different opinions about that. Some say that even at 32, a hypothermic victim may have ventricular extrasystoles or malign arrhythmia. And others say, okay, with 30 centigrades, it begins to be dangerous. And some say below, you need a core temperature below 28. So it is a compromise. And we still think that we should be on the safe side. And it is a consensus decision. It is not based on real big data, you know. And the recommendation has been developed among a group of about 50, 60 experts, mountain rescue doctors within the International Commission of Mountain Emergency Medicine of ICAR. And it is an expert consensus, no more. And they are recommendations and it's not a protocol. So it is legally not binding. You know, if a doctor who is responsible for extracorporeal warming decides not to resuscitate above 28, it is a decision that should be justified, but it is free. So every doctor is free to decide according to additional symptoms, additional parameters and results of the blood tests, etc., etc. And so it is not 100% waterproof at 30 centigrades. Again, the 60 minutes, I agree completely with you. It is maybe in many cases too long, and one can go down to a lower temperature that's lower than 30 centigrades within shorter time than 1 hour.
And probably the decision making depends on the resource. If you have resource,
exactly,
you strictly follow the recommendation. With in case of mass casualty incident, it will be different, and probably you have to choose. It's what is interesting is about the OPS score that the rescue colors did not match, but it could be it's not intuitive. Question?
And recommendations, they are made not only for us Europeans, but they should be applicable also in North America and in Canada, where we have much less resources than we have in the Alps. So in the Alps, for instance, if you have one doctor, one patient, one avalanche victim, and you can use the full resource for each patient, then I think we could be very, very liberal to bring the patients to hospital, much more than maybe in a multiple victim accident where we have lower resources, and then a triage is justified. Otherwise, I think it's better to bring the patients to hospital and make the triage in the emergency room. But not all the hospitals agree with that.
And something that could be tricky during rescue is cooling rate, fast cooling rate. It's not easy to understand. And when I've looked for the case reports, everybody died. So it's not for the young doctor. I think you have to know the recommendation, but you have to know every article and history. Okay, thank you, Herman, and thank you for this historic overview. And I would like to ask to Bernard Marsigny. It will not something about history, but prehistory. Prehistory. Bernard is he will present himself. It will be better. Bernard told me how to intubate when I was a young kid, young doctor. And he will explain to us the fabulous history of extracorporeal facilities in the old hospital of Chamonix.
Change slide?
Yeah, please.
Yeah. Okay. Yeah. Do you hear me? Yes. So I need my paper. Lunettes de vieux. Lunettes de vieux. So, as a mountaineer and anesthesiologist, I worked for nearly 15 years at the Chamonix Hospital at the end of the last century. When I was recruited in 1987, the job description required prior experience or training in cardiopulmonary bypass. Strange for a small establishment without cardiac surgery, but it was real. Thanks to Jacques Fauré, a surgeon from Chamonix, a major contributor of study on frostbite and hypothermia, the hospital has been authorized in April 1982 to acquire extracorporeal circulation equipment intended for rewarming hypothermic patients on a specific and experimental basis. April 82 is also the date of publication of Holthaus' article, which reported the survival without sequelae of 3 hypothermic patients in cardiac arrest. 2 of them were resuscitated thanks to cardiopulmonary bypass. Finding any resuscitated cases in Chamonix between 1982 and 1987 proved impossible. There is no explicit mention of it in the scientific publications, and the records from that time have been destroyed. I tried to contact my predecessor in that position, who had considerable experience in cardiac surgery, but I was unsuccessful. However, I did manage to find one of the nurses who had been trained as perfusionist. She is now a musher and raises sled dogs in northern Finland. She remembers participating in at least 2 cardiopulmonary bypass procedures, both of which failed. In short, in the fall of 1987, I was reading some course material on CPB, and after 2 mornings in the cardiac surgery unit in Geneva, I knew how to set up the circuit. A modest experience, all things considered. Lacking a powerful helicopter, we were the first recipients of these patients. In truth, given the limited technical environment available and the experience of the various personnel involved, we reserved CPB only for desperate cases. Avalanche victims or those extracted from a crevasse in circulatory arrest. However, most of them were polytrauma patients or asphyxiated with potassium level well above the limit. The best we could do was to recover transient cardiac activity. Finally, lacking conclusive success, we returned to tried and tested techniques, passive rearming and close monitoring in cases of satisfactory circulation, or warm fluid resuscitation with pleural and peritoneal irrigation associated with cardiac massage in cases of cardiac arrest, with some success. To illustrate this pioneering era, here are some photos of one of the last CPBs performed on an unfortunate driver of a snow groomer which had fallen into a wide crevasse below Pointe Elbonner on August 3, 1990. Summer skiing was still practiced there at the time. On the left, the winching of the victim installed on the piggy-lamb to extract him from the crevasse. In the middle, a colleague nephrologist, Philippe Nicou, monitoring the CPB machine. And on the right, the late Emmanuel Cauchy, the doctor vertical of 1990s, securing the femoral access. Sadly and ironically, Manu died in an avalanche in 2018. At the turn of the millennium, the arrival of the EC-145, a helicopter capable of quickly transporting hypothermic victims to major cardiac surgery centers directly after their extraction, changed everything, but that's another story. Short.
Thank you, Bernard. Do you have a question for Bernard?
Bernard.
Yes.
Bernard. Great to see you.
Me too. I saw you 25 years ago.
I remember in the 1990s in Chamonix, we met together with Emmanuel Cauchy, and you both were pioneers. It's really a great pleasure to me to see you again after such a long time. Great. Thank you so much.
Thank you.
Bon, je vais vous la faire en français. L'idée m'est venue d'inviter Bernard parce que bon, bah, c'est pour de vrai, hein, c'est lui qui m'a appris à intuber. Et l'histoire, je crois que j'ai trempé dans cette histoire hein, du conducteur de Dameuse qui était tombé dans cette crevasse. Et c'est vrai que ça me paraît, aujourd'hui, ça peut paraître complètement délirant de se dire que dans ce petit hôpital, et c'est vraiment petit, hein, c'était l'internat, c'était une maison bourgeoise, le Regina. Et le chirurgien, il faisait tout, du digestif, de l'orthopédie. Il y avait un service de soins intensifs et j'ai même vu naître une dame qui a accouché avec un enfant qui avait une tétralogie de Fallot, avec le SMUR de Bonneville qui attendait, dont le médecin c'était un résident premier semestre. Donc c'était il y a ouais, presque une quarantaine d'années. Et mine de rien, finalement, après, ça a beaucoup changé. L'hôpital.
Everything has changed, yes. But 2 surgeons, 2 anesthetists, 3 interns, maybe 3, 4 interns. Yeah, very small hospital, and the CPB was not in the right place.
Et bien sûr, à une époque où il n'y avait pas de téléphone portable, quand Forêt, le chirurgien, il partait, il disait « vous me trouverez…
in the river because he was fishing, yes. yes, it's special. But it's nice years, yes, very good souvenirs.
L'autre chose, what is interesting in this case is that even if cardiac bypass never work in Chamonix, but
we try.
Basic way with external reform saved a lot of lives. And
we have some success, even with peritoneal and pleural massage, yes. Yes, it was possible to rewarm, but it's less efficient than the circulatory extracorporeal circulation.
And maybe we have to keep in our mind that there is not a lot of ECMO available, and maybe one time it will be necessary to make again a peritoneal lavage. It can be useful. Thank you, Bernard. Thank you, Giacomo. Thank you, Herman. Et merci à vous tous. Merci à tous ceux qui ont été à distance. On va se quitter. Et je vous dis peut-être à 2027 pour une autre page de l'histoire du secours et de l'avalanche. Voilà. Et puis, il va y avoir un Fergus là qui... on va vite aller au Fergus pour ceux qui ont prévu de manger à Grenoble et nos amis de Chamonix. Merci à Urg'ARA pour le soutien logistique, pour nous avoir permis de nous mettre en contact avec Future Prod, et puis à l'université, à l'UGA, au CHU, et puis à vous tous. À bientôt.